I'm happy to be the last person before I'm your ticket to get to lunch. So, Roberto, one more after me. Okay, that's true. I'm starting a little late, so I'm going to try and go a little bit quickly and get us onto schedule now. Neil did an excellent job of covering lung mechanics, and I kind of view my job as the person to build on his coverage of mechanics and move you into the how do I digest the literature towards practical application with my patients to the bedside. So I'm an intensivist who works at Vanderbilt University. Vanderbilt and Duke, where Neil McIntyre is from, both participate in the ARDSNet clinical trials, and so we've been collectively enrolling patients for the last over 10 years now, hard to believe, into these ARDSNet trials. And I'm going to take this opportunity over the next 35 minutes with you to review the gamut of the literature on what I call the front end and the back end of mechanical ventilation from a clinical trial perspective. The front end of mechanical ventilation being the time that you first see your patient, get them into the ICU, and place them onto the ventilator. How do you set up things for the patient at that time? Tidal volume, PEEP, medical management of severe sepsis, etc. And then the back end being once the patient has ascended that mountain of injury and then begins to plateau in injury towards recovery, how do we then begin to remove all of the things that we have put on board as life-saving tools for the patient? And one of the take-home messages in the second half of my talk is the removal piece, that back-end piece. And the reason that I want to emphasize this is because we in critical care spend so much time focusing on the beeps and the buzzers and how we get things started that one of the deficits in our management plan is the removal of potentially injurious interventions that we have put on board, such as positive pressure ventilation, heavy doses of sedation, analgesia, paralytics, etc. So, it turns out that in the past 10 years, one of the most consistent areas of evidence of positive clinical trials in critical care has not been the institution of the therapies, but the timely removal of them. So my tandem is going to be front end, back end. We're going to start with the front and move to the back. The other thing I wanted to say in answer to the woman who asked about do we use low tidal volumes in normals, I was just going to kind of rephrase what Neil said and remind you that right now you are all breathing at 6 mLs per kg. So we actually refer to it as normal tidal volume ventilation, where you're giving the patient what is normal rather than doubling what is normal to the 15 mLs per kg. We give you 6 to 8. So my patients who have normal lung volumes, I give them normal tidal volumes, which is in general 8 cc's per kg. If you have injury, we go lower to 6 or 4 even sometimes. Okay, with no further ado, let me move forward, but I have not... Is it this way? I didn't really pay attention to how to get my next slides. Green button, thank you. So, we're first going to remind ourselves that the disease we're talking about clinically at the bedside is ARDS. And on the film, we're going to see the patient who has a diffuse type of lung injury, which is manifested by infiltrates bilaterally with a fairly normal cardiac silhouette and a normal vascular pedicle width. On the clinical exam, the chest exam, when you do not any longer use Swan-Ganz catheters as often as we used to, you'll remind yourself that in a supine patient, the distance between the lateral borders of the superior vena cava and the subclavian artery should be something in the less than 70 millimeters or less than 7 centimeters range. These are associated with wedge pressures in the low teens. That normal vascular pedicle plus these diffuse infiltrate pattern makes the picture of non-cardiogenic pulmonary edema. If you look at the CT scans, such as those that Neil McIntyre showed, you'll remember once again that what you are ventilating with is the top superior portion, or anterior portion, I should say, of the lungs, because we're doing baby lung mechanical ventilation. High PEEPs do recruit more lung. Notice how these baby lungs get larger when the PEEP goes up from 5 to 15. And we know that that improves oxygenation, but does it improve survival? And that's one of the clinical things that I will cover with you today from clinical trials. We also know that there have been a myriad of things that we have done in critical care in the past 15 years. And interestingly enough, I thought I would point out to you the epidemiology of this disease, so that when you're talking with your patients, you can tell them, hey, you know, when we first started driving this car of the ICU back in the early 80s, we were not that good at this. When you got ARDS, you were pretty much going to have a 60% or higher mortality rate. But over the years, we did lots of things in the ICU that caused a reduction in death rates into the low 30s for the most part. And since that time, it's been hard to get the mortality rate any lower. If you look at this second reference down here, and I'm very reference happy in my slides. I like to put a lot of peer-reviewed literature on the slides so that you can go back and pull articles that you want to pull. This last article by Fua showed us that there has actually been somewhat of a stalemate over the past 15 years, and no progressive reduction, at least in this investigation, through the mid-2006 range. Looking at 90 studies, there was a leveling off of the mortality such that in 20,000 patients reported, the mortality from observational studies was in the 40 to 45% range, and for randomized controlled trials, where we always see a slightly tighter approach to medicine and sometimes lower mortality rates than in quote real world, there was a 35 to 40% mortality rate. So the take-home message is, yes, we've gotten better, but nevertheless, it is still a very dangerous disease. And in the medical ICU patient, or that with surgically induced sepsis, et cetera, you're going to have about a 1 in 3 chance of dying before you leave the hospital. That is not true for the trauma ICUs, where it's much lower than that, because generally people are younger and more healthy. But those are some data that you can take into your conversations with families. Age is a consistent factor predicting increased mortality, and there's a lot of things that go into that. I wanted to point out to you that the main disease that we are talking about here that is leading your patients to getting ARDS is one of infection or aspiration. Trauma and multiple transfusions play a role, but it's much lower. And in the United States, we're dealing with very large numbers in terms of number of cases and deaths per year. This is an excellent slide published by Gordon Rubenfeld, which shows one important take-home point. Look at this solid line and the incidence of ARDS, and look at how it skyrockets with advancing age. And then look at the second line, which is the patients with sepsis. And notice how they mirror one another. Sepsis, a disease of aging, is the main disease we're talking about leading to acute lung injury and ARDS. Certainly there are other causes, but in general, severe sepsis, ARDS, same deal, and your severe sepsis patient, the most common organ dysfunction they're going to have is lung, the most common cause of lung failure is sepsis, and so on and so forth. So this is a very important thing to keep in mind when you're talking about the epidemiology. Regarding age, this is a paper that I published in the Annals of Internal Medicine several years ago looking at the ARDSNet data, and as you went up from deciles of age, 30s, 40s, 50s, 60s, etc., you can see there's this very nice stepwise reduction in survival as you go up in deciles. That's the first point from this slide, but the second point that the editor of the Annals pointed out to me was, hey Wes, notice though that even the octogenarians still have a 50% survival rate. So shouldn't we emphasize that if we are age biased and take our older people and tend to not put them on life support, we're going to get it wrong half the time. And I thought that was an excellent point that I now emphasize, which is I don't like to use chronological age as a means by which to determine whether or not somebody should receive life support based on data like this. Now, another big take-home point that I want to emphasize, and I'm going to do so later on as well in my delirium and sedation lecture, is that much of the comorbidity or the life dismantling that occurs for our patients when they leave the ICU after ARDS is non-pulmonary. It's almost as though when the person comes through the door to be taken care of by you, their ticket to get into your ICU is lung failure and the need for a ventilator. But right under your very nose, while they're being cared for by you, they acquire other problems. And I like to point out two extremely common acquired diseases, which are neck up and neck down, the neck up one being delirium and long-term cognitive impairment, and the neck down one being critical illness myoneuropathy, or what's now referred to as ICU-AW, ICU acquired weakness. So many of your patients, just be aware that their survivorship is going to be fraught with generalized weakness, cognitive disability, affective disorders, reductions in quality of life, and many of these patients are going to have recurrences of illness because they are forced into a life of becoming a couch potato and or inability to go back to work, run their family, run their business, or even perhaps find their car in a parking lot, etc. So we have to pay attention to this, and if we are going to be good stewards of our patients' lives, we need to try and plug these people in to routes of care that can deal with some of these areas that they have acquired diseases beyond the clavicle to diaphragm. And I'll come back to that a little later. So remember, non-pulmonary comorbidities may be the main determinants of survivorship after ARDS, and I like to say the lung bone is connected to the brain bone. Just to wet your whistle, we are finding that about 2/3 to 3/4 of ICU survivors have a long-term cognitive impairment commensurate with a mild to moderate dementia. And we're seeing that it lasts in over half of them well beyond a year. So this is an acquired form of dementia which tremendously impairs their ability to get around and get along in life and follow your directions since they can't remember things as well as they used to. So now we shift into let's digest the literature on the lung. And how do I practically apply this at the bedside? So the ARDSnet literature is a good framework within which to drive this car through the land. So we're going to talk about the high tidal volume, low tidal volume that Neil already brought up. We're going to talk about high-low PEEP, steroids. We're going to talk about Swan-Ganz catheters versus CVP management. And we're going to talk about fluid, liberal versus conservative. And then I'm going to bring up at the very end of this section of the talk some things like ECMO and proning and that sort of thing, based on all of this based on RCTs. And please bear with me as I do this. Remember, we started about 20 minutes late, so I'm going to, rather than focus on the trees, I'm going to focus on the forest. I want you to leave with the take-home points. You can go back to these slides and digest the specifics of all these graphs later. I'm not going to dive into the specifics of the graphs just for sheer emphasis on time and getting you to lunch, okay? All right, what are the main points? What if you divide people up in a randomized control way into a higher tidal volume, 12 mLs per kg, or a lower tidal volume? Well, you all know the results of this trial, so I'm going to speed to the end here. But basically, the experiment was done. You can see how well they were divided. You can see that the rates were higher in those with the lower tidal volumes. You can see that the PCO2s were higher in those as well with lower tidal volumes. The plateau pressures were maintained below 30. That's that estimate of transpulmonary pressure that Neil McIntyre was trying to get us to focus on. And there was a transient difference in P over F ratios as well in favor of the higher tidal volumes. The big take-home, though, was that there was a 10% reduction in mortality in those who got the normal tidal volumes, the 6 mLs per kg. And remember, I'll try and add to the things that Neil already talked about. Remember, a way of expressing this is number needed to treat. If you have a 10% reduction, that's your ARR, absolute risk reduction, is 10%. If you want to get the number needed to treat, you take the reciprocal of that. So 1 over 0.1 gives you a 10. That means that these data show that for every 10 patients treated with a normal tidal volume, a 6 versus a 12, that you have one life saved. That's a free intervention. Turn the knob down, and you get a life saved every 10 times. That's a very low number needed to treat. The ventilator-free days went way up, much more time off the mechanical ventilator. And here is, as I said, a little lagniappe, a little something extra. I'm a Louisiana boy. You know, I grew up riding them alligators to school down in Louisiana bayous. So we believe in lagniappe, a little something extra. And this is to remind us that while the target plateau pressure was 30, that in this paper published by Brower, that the mortality rate here, shown on the y-axis, was progressively lower the lower you went in plateau pressure, even below 30. So I always tell the residents and others managing the ventilators that if your patient's comfortable with a plateau pressure of 20, use 20. 20 is better than 25, and 25 is better than 30, as long as you're achieving comfort, synchrony, etc. And I base that on these data from the ARDSNet. Now, moving to the second thing. What about once you've set up the ventilator, this is still on the front end of mechanical ventilation, you've set it up to this normal tidal volume area, what sort of PEEP should you seek to achieve in that circumstance? Well, there have been 3 major trials I want to review with you. This first one was published in the New England Journal by the ARDSNet back in 2004. And the first thing I want to do is let you look for a second at this PEEP chart. Look at the orange bars in the front and just get a feel, since some of you may not have looked at this recently, and you're out there in the world practicing medicine, all of us. Look at the general areas that were considered kind of like the normal approach to PEEP in ARDS. So if you're 30, 40%, PEEPs are in the 5 range. As you move to 50, 60, 70, you're moving into the 8, 9 range. You're still in the single digits until you get to about 80, 90%. And at 80, 90%, you move up into the double digits of PEEP. I think it's a good framework for all of us to have. So double digits of PEEP around 80, 90%. Now, up against that control, people tested adding about 5 or 6. What happened when you did that? Okay? Well, there have been, as I said, these 3 major studies I want to go over with you. I'm going to show them all in a summary, so it won't be belabored. It'll be a way you can digest this, and all of us can kind of easily remember what was found. Okay? I'm your digest the data guy today. The studies were alveoli, loves, and express. And I would like for people to feel comfortable reciting this literature. I want you, when you walk out of here, to say, look, I know the PEEP studies. There were alveoli, which was the ARDSNet study. It was loves, which was the Canadian study. And it was express, was the French study. And there's a few things you can remember about each of them. The alveoli study used the PEEP table I just showed you. All the plateau pressures were held below 30. And one of the problems with that study, there was an age imbalance in favor of the younger people being in the control arm, I believe. Against the high PEEP. In the Canadian study, which this stands for Canadian Critical Care Trials Group, this study took 6 years. It was on 3 continents, and it was 30 hospitals, giving you a magnitude, a big study. They used a PEEP table as well. Plateau pressures were less than 30 or less than 40 in the 2 arms. And then the French trial, 37 ICUs, all of them got normal tidal volumes. The control PEEP was a 5 to 9, and the treatment PEEP, they increased the PEEP to keep the plateau pressure around 28 to 30. So there were slightly different approaches, but they all found the same thing. So don't get all bogged down with the slightly different approaches. They all found the same thing. In general, the PEEPs were, as I said, single digits on average in the control group, and at about 5 for the intervention group. Okay? And the mortality rates were the same in all 3 studies. This is alveoli, loves, express. There's no significant difference here. And the pooled mortality rate was everybody died around 34, 35%. Okay? So changing that PEEP on top of the normal tidal volume approach did not change things much. Now, there's a couple of caveats. All 3 studies were negative for mortality. Survival was a little bit different in express. The sicker you were in the French study, the sicker patients tended to benefit a little bit more from the higher PEEP. So if you are a person leaning towards higher PEEP use, I think that you would have a little bit of data from express to support that in bad ARDS. Okay? But outside of that, there's not much data to use high PEEP above what I showed you on those orange bars in the normal PEEP table of ARDSNet. Now, here are some things that I found tucked away in these studies that I think are really important for us in critical care. When you were in the ICU, think about this. All of those studies, sepsis, main diagnosis. Look at this. 65, 90, and 85% of the cases. This is the disease you're talking about with ARDS. It's severe sepsis. Okay? Weaning protocols. They have evolved in a very interesting way, such that all three of these international studies abandoned the FORVT, exactly like Neil said. I don't think the FORVT is bad. It's a fine, mini look at how the patient's doing. Turn the ventilator off, CPAP only, and see how they breathe for a minute or two. And unless they're just completely falling apart, the point is keep them on that mode and watch them in CPAP for a spontaneous breathing trial, which we'll get in a minute. All of these studies used 2-hour spontaneous breathing trials, and they all prompted the doctors. This is not to be underestimated. In all of these studies, this is now over 100 ICUs if you add them all up together, in all of them, if the patients passed an SBT being done by a therapist, they told the attending physician. Is that happening for you? I'm asking you that question. Is that happening for you? Every day, is your patient being tested for removal of the ventilator? Are they being turned off, watched for 30 minutes to 2 hours, and is somebody coming to you and saying, Dr. Smith, Miss Jones passed her SBT today? If that verbal prompt, that connection, that communication is not happening, you are missing. And your patient is the one suffering in terms of potentially longer time on the ventilator. So just remember that. We'll come back to it. Interestingly also, Love's reported 95% of sedatives and narcotics for 1 week. Hello? 1 week of narcotics and sedatives in 95% of the patients. That represents a culture that we need to have going away. That is overuse, overexposure of sedation and analgesia. We always want pain-free, but these are bygone days, and there's a lot of data to support that this keeps the patient on the ventilator longer than anything else that you're doing. I'll come back to that in the delirium lecture a little later. Steroids, out. Some of you no doubt use steroids. I don't think that that's malpractice or anything, but there's not a lot of data to support it from randomized controlled trials. This is the ARDSNet study adding steroids on after a week. You can see there is no difference in the survival curve or in the mechanical ventilator curve. Pulmonary artery catheters. Okay, let's talk about this and fluid, dividing the ARDSNet study up into two different types of experiments. And again, this is an entire lecture in itself. I'm going to cover this in just a couple of minutes with the take-home points. What happens if you take 1,000 people on ventilators, most of whom have sepsis and ARDS, and put them into one of four groups? On the down columns, you divide them up into a conservative versus a liberal fluid management strategy. And on the horizontal bars, you divide them up into pulmonary artery catheter management approach versus central venous catheter approach. So we'll do the PAC first. Before we get anywhere, I want to remind you of what the algorithm showed. Let's digest this algorithm. A couple of take-home points. If you have a low mean arterial pressure, this is always going to be managed with resuscitation, aggressive resuscitation. This is not where we asked a question about liberal versus conservative fluid. Everybody here gets vasopressors and fluid. After you have recovered your mean arterial pressure being low, you're out of shock, then you move progressively towards one of these two boxes. We said the lower right of the algorithm, where you either place in conservative management with Lasix or liberal management with fluid. The take-home point that I'm about to show you is that when you're here and you divide the patients up into management by a Swan-Ganz catheter and a wedge pressure versus management with a central venous catheter and CVPs, there was no difference in outcome with those two management strategies. There was a difference in outcome related to time on mechanical ventilation and time in ICU in favor of conservative fluid and Lasix over that of liberal fluid with less Lasix. So that's what I'm going to show you. That's the take-home. Let's just skip to the chase. Everybody was balanced at baseline. Baseline characteristics, once again, were balanced. All of these things were balanced. Blood pressure, heart rate, CVP. The experiment seemed to have randomization worked. The patients were even. And you can see the take-home point here is that the mortality curves for the wedge, the Swan-Ganz catheter versus CVP and CVC, central venous catheter, were superimposable. No difference whatsoever. And by the way, that mortality outcome, that similar outcome with a Swan versus a CVP, a central venous catheter, that has also been repeated in 3 other international studies. Sandham, and then if you want to look them up, Sandham in the New England Journal Canadian study, the Pacman study, Pacman in England, and the Richard study, in France. So this is the 4th large RCT showing no delta between Swans and central venous catheters. You can also see that the lower curves here, these are on time on mechanical ventilation. They were also not changed. But that experiment also did fluid, liberal versus conservative. And you can see that an experiment was done here. In the red bars is going to be the conservative, think Lasix. Look how much more Lasix was given. In the orange bars is going to be liberal, less Lasix, we want fluid. So you can see that the liberal, a lot less milligrams of furosemide than in the conservative. Just look at this top graph here, net fluid balance in the liberal group. You can see that cumulatively there was about 7 liters more of fluid. Over time, about 7 liters more of fluid. And they had nice separation of central venous pressures and of pulmonary artery occlusion pressures. There was, let me just move on here to the chase, which is terms of survival. The mortality rates in the liberal arm were about 3% higher death rate than the conservative arm. That was not statistically significant. But there was a big difference in time off the mechanical ventilation in favor of about 2 more days off the ventilator in the conservative group. That's alive and free of mechanical ventilation. And this shows you that there was about 2 more days also alive and out of the ICU in the conservative group. So the point, remember I said earlier about the front end and the back end? Remember? The point here is that on the front end, it doesn't matter so much how you manage that shock. That is the tool you use, a Swan versus a CVP. But you just need to manage it aggressively. But after you're out of shock and you're on the back end of this, the overriding conclusion is that shunting the patient towards more conservative fluid management with more Lasix and less volume in and more volume out gets them off the ventilator and out of the ICU more safely. It also showed that there was significant improvement in the number of days with central nervous system normality. That is, lack of coma, lack of brain abnormalities. And this could be due to less cerebral edema from more diuresis, or it could be the fact, which is my hypothesis, that patients who were being removed from mechanical ventilator earlier because they had less pulmonary edema, because they were more diuresed, got taken off of sedation earlier, and therefore their brain came back earlier. So I think that there's lots of reasons that could be, but there seemed to be no downside to the conservative approach. So the conclusion in all of this is that you should use a normal tidal volume. You should use a PEEP level that you like and don't be feeling compelled to give very, very high PEEP levels. That steroids improve oxygenation but not survival. I didn't show you the oxygenation piece, but there was no survival outcome. Routine use of pulmonary artery catheters should be avoided. I did not say all pulmonary artery catheters should be avoided. There's probably a 5% of your patient population where you think a Swan is indicated and helpful. Do that. And then application of fluid conservative protocol after resolution of shock is appropriate. Now, we started a little late. I see you get up. I was going to do the second part of this. I could do it in 5 minutes. I've almost got us back on time, but I do want to leave them with the major take-homes from the back end of the removal of mechanical ventilation. So let me do that. The goal on the back end is getting you from point A to point B, on the ventilator to off the ventilator. Science is knowledge based on observed facts and tested truths, arranged in an orderly system. I put this up here because people say, are weaning protocols science? Is there science there? And I think it is. I think that protocols are scientific if you've derived knowledge from observed facts, tested truths, i.e. randomized controlled trials, and arranged them in an orderly system. That's the definition of science. This is science. Now, it's a little bit warm and fuzzy here because of this. A lot of protocolization success is inherently dependent upon your ability to get people to work together. And people are tough. Here you're talking about getting nurses and therapists and doctors and PAs and NPs and pharmacists, et cetera, to work together. And the most important take-home message that I can give you on this back end of mechanical ventilation, which I'll emphasize a little bit here, but I won't go into in great detail. I'll talk about it a little bit more in the delirium lecture later so that we don't get behind here, is this, that linking sedation approach and weaning approach has to happen in your ICU for successful approach to your patients. These are inextricably linked because the sedation puts the patient's brain down, which makes them look like they need a life support system. Then they need the life support system because when you turn the ventilator off, they don't breathe because their brain is down because of the sedation, et cetera. So you have to bring these two things together. And I'm going to show you some pretty strong evidence that when you link sedation protocols and weaning protocols together with nurses and respiratory therapists and doctors all working in context together, that your patients get off the ventilator and out of the ICU a lot faster. And it saves their lives. Pigs can't fly. Why? Because pigs are heavy, they have minimal thrust, no lift, limited control. Birds are light, adequate thrust, good lift, and have excellent control. Every system is designed to do what you wanted it to do. Your ICU is the same situation. You have to realize your ICU is a structure and an organization, and the structure and organization of it is at least as important as the technology. The Pareto principle says 80 to 85% of opportunities to improve relate to flaws in systems that hinder the individual's ability to do their job. Part of that is that your ICU is complicated, and if you don't make a protocol and establish a way to enable the patient to be removed, the path of least resistance is to leave the patient on the ventilator. So, Neil McIntyre showed daily spontaneous breathing trials were shown to be improvements over IMV and multiple times a day. We showed almost 15 years ago now that protocolizing removal from the mechanical ventilator in the ICU improved time on the ventilator by about 2 days. 2 days less on the vent. And I'm going to take you to a real-life example of this. The current sepsis guidelines say, with a grade 1A evidence and grade 1B, that using weaning protocols and spontaneous breathing trials regularly to evaluate patients for discontinued mechanical ventilation is a very strong recommendation. They also recommend using sedation protocols. Notice these are linked here, sedation and weaning. So I'll build the case for how to do that in the next lecture. But let me show you one last take-home point and then make a few comments, and I'll take a question or two if you have them. Deming said, in any process, reducing variability in that process inevitably leads to greater efficiency and lower cost. In your slides, in the remainder of the talk, one of the things I show you is a lecture from a French group that did this. They implemented a on-paper protocol. And then 2 years later, they went on. You don't have to find it. I'll just tell you what it shows. You can go back and look at it later. I'm going to try and be respectful to the next speaker and just give you a summary. After 2 years of having implemented this on-paper protocol, they then set up a way that it did not take the people to drive the protocol. They made a computer do the same exact thing. So half the patients were managed with the person-driven protocol, and half the patients were managed with the computer-driven exact same thing. Everybody's getting the same thing, except in one case it has to happen. And you know that patients came off the ventilator 2 days earlier, 3 days earlier in the computer-driven approach. My point is that you need to strive to implement with an 80% or higher compliance whatever you believe to be the most evidence-based approach to your patient management. And you should follow the compliance rates in your ICU to make sure that these things are attained and maintained. What you're doing in January isn't necessarily what you're doing in April and July and the next September. You have to repetitively do this, and over time, your ICU will change its culture. The last couple of take-home points I'm going to give you are that regarding the ICU management of ARDS, ECMO was just proven to, they just did a large randomized controlled trial of ECMO in Britain, and the referral to an ECMO center with a large, complicated approach to ECMO seemed to provide a survival advantage for bad ARDS. But the evaluation of this investigation was more that it was the things that came with a fancy ECMO center and not the ECMO itself. So most people are not using ECMO even in profoundly bad ARDS in the United States, but there are some evidence to reopen that can of worms. And if you want to look that up, you can look up the Caesar study published by the Britons this past year. Proning will be my last point, in that the last and most definitive study of all of proning was just published by Luciano Gattinoni in JAMA. These slides, it was too new to make your handout. These are all more recent than I had to submit these slides that you have about 3 months ago. And that study was again negative. There have now been 4 large randomized controlled trials, all showing that proning improves oxygenation, none of which showed that proning improved survival. So I do not think you should feel compelled to turn your patients over, even though that would improve their oxygenation. There are complications that come along with it, and it did not end up causing patients to live more often. So with that, Henry, I think I'll stop, make some room for the next speaker, and if anybody has any questions, maybe I'll take one or two from you. Yes, sir. Please go ahead and I'll repeat it.